Dear students, we are in the 24th part of the wrist and hand complex. So, after understanding more about the extrinsic finger extensors, in the same area, we are going to the extensor mechanism. So, once you understand the extensor mechanism, so we will be completely understanding about the extensor finger extensor muscles. And so extensor mechanism we have already understood is a foundation of the found by the tendons of the EDC muscle, EIP, EDM muscles, the extensor hood, the central tendon, the lateral bands that merge to the terminal tendon. The first two components that we will add to the extensor mechanism are the passive components of the triangular ligament and the sagittal bands. The lateral bands are interconnected dorsally by a triangular band of superficial fibers known as the triangular ligament or the dorsal retinacular ligament. Here you can see that this is the triangular ligament which helps in maintaining the stability of the lateral bands, and so this helps in maintaining the stability of the extensor mechanism. The triangular ligament helps stabilize the bands on the dorsum of the finger. The sagittal bands connect the volar surface of the hood to the volar plates and transverse metacarpal ligament. So we can say that the triangular ligament, the volar plate of the flexor compartment of the finger, and the transverse metacarpal ligament together they form a bond which stabilizes the whole fingers, the musculature. The sagittal bands aid in stabilization not only of the volar plates but also of the hood at the MP joint. So sagittal bands also stabilizing the not only the volar plates but also the hood of the MP joint, that is metacarpal phalangeal joint. The sagittal bands help to prevent bowstringing. The same way the annular ligaments are preventing the bowstringing of the flexor tendons, which we have studied earlier here, the sagittal bands are preventing the bowstringing of the extensor mechanism during active MP joint active extension, as well as transmitting force that will extend the proximal phalanx. So you understood that the main aim is to stabilize and to prevent the bowstringing of the extensor mechanism during active extension. The sagittal bands are also responsible for centralizing. See, the EDC tendon can go out, to shift to sway. So preventing that to keep the EDC tendon exactly in the centralization when they are flexion or extension of the MCP joint happens. This prevents tendon subluxation. So if same way stabilization of the EDC tendon in the center, prevention of bowstringing are the important things, along with the stabilization of the volar plates also important. Now we'll see about the muscles. The passive muscles, which are where even though the muscles position is in the flexor area, they have an important role to play in the extensor expansion or the what we call as the extensor mechanism. The dorsal interosseous and the volar interosseous, otherwise called as palmar interosseous, and then the lumbrical. So interosseous together we see as a single musculature, even though the two parts have different action in the adduction abduction of the fingers, and lumbricals are the other part, are active components of the extensor mechanism. So they have an active role to play in force generation in the extensor mechanism. The DI and VI means the dorsal interosseous and the volar interosseous muscles arises proximally from the sides of the metacarpal joints. Their origin is from the from the sides of the metacarpal joint. Distally, some muscle fibers go too deep to insert directly into the proximal phalanx, whereas others joins with the with and become part of the hood that traps. So attachment is basically to the sides of the proximal phalanx as well as to the expansion hood. The interosseous muscles may also contribute fibers to central tendon and both lateral bands. That means these interosseous muscles attachment is both to the proximal phalanx, to the extensor expansion, that is a hood, and also to the EDC central as well as lateral bands. So that means that they are actually attaching to the EDC itself, the extensor mechanism. The attachment is totally to the extensor expansion. So then when they contract, they will produce extension along with their desired action. That is, for the dorsal it is going to be abduction, and for the volar it is going to be adduction of the fingers. But along with that, they produce extension. Why? Because the attachment is directly to the EDC tendon only, the central tendon, the lateral bands, the extensor hood, and also to the bone, that is a proximal phalanx. Whereas the lumbrical muscles attach proximally to the FDP tendon. The lumbrical muscles are not attaching to the extensor tendon; they are attaching to the FDP tendon, and distally, proximally, they are attaching to the proximal. Two attachments are there. One attachment proximally to the flexor digitorum profundus, which is a flexor muscle, extrinsic flexor muscle, and other attachment distally to the lateral band, with the addition of the oblique retinaculum, that is a what we call as the ligament, triangular ligament also. So here you can see the lumbricals, which is how they are coming, and they are attaching. The proximal attachment will go inside. We cannot see that, which is in the opposite side. They will go and attach to the flexor tendon. Then the other part is attaching to the extensor expansion hood, and also to the lateral band. See the lateral band, how the lateral bands are going. This is the central tendon, right, of the EDC. So they will attach, the lumbricals will attach. And here you can see the interossei. Both the dorsal and volar interossei are going and attaching to the extensor expansion, and also you can see extensor expansion also to the EDC tendon. Both, so they all, when they join, they are merging to all the bands, lateral band, central band, extensor expansion all together. You know, so EDC tendon. So you can clearly see that in this picture. Now you understood about what the extensor mechanism is. Now we'll only have to see how the extensor mechanism influence on metacarpophalangeal joint and interphalangeal joint. With that, we will come to an end. So we will just see how the extensor mechanism influences on the metacarpophalangeal joint function. The EDC tendon passes dorsal to the metacarpophalangeal joint axis. An active contraction of the muscle creates tension on the sagittal bands of the extensor mechanism. So sagittal tendon active contraction creates a tension on the extensor mechanism, pulls the bands proximally over the sagittal band is pulled proximally over the MCP joint, extends the, so this will produce extension of the first phalanx, that is a proximal phalanx, in order to simultaneously, so this will extend what, the PIP, proximal interphalangeal joint, and therefore the EDC muscle again the contracts, so this will also extend the DIP joints. The EDP muscle required assistance from whom? Already we understood. DIVI, that is dorsal interossei, volar interossei, lumbrical muscles. So together, when this happen, if these three, there is two muscles, we call them as three muscles, two part of them together, when they contract, they assist, and then the strong extension of the PIP and DIP also happen. So MCP joint also extends. Also with that, what will happen is PIP and the first. So here they have a major role in MCP joint extension. Each of these muscles passes volar to the MP joint axis, and therefore creates a flexor force at the joint. However, when the EDC, interossei, lumbrical muscles all contract simultaneously, the MCP joint will extend. So when they all together contract, they will extend the IP joint, because the torque produced by the EDC muscles at the MCP joint exceeds the MCP joint. See, you have to understand, when this happen, normally the lumbrical muscles are there, but they go and attach to the FDP muscles, but that do not produce flexion at the IP joint. Why? Because the IP joint torque, flexion torque produced by the lumbricals is less than what the extensor torque produced at the MCP joint. So this will produce, so the intrinsic muscle torque. So lumbricals are, and volar and dorsal interossei are intrinsic muscles. So the intrinsic muscles torque generation is comparatively lesser than the it is there, but they cannot produce flexion contraction. An isolated contraction of the extensor digitorum communis muscle will result in the metacarpophalangeal joint hyperextension. So in isolated, so if you're seeing only the other muscles, which are the interossei, the lumbrical, they are all supplied by the ulnar component, right? They are in the flexor component. So when these muscles are, when the muscles are not supplied, when their nerve supply is affected, so only the extensor digitorum communis muscle is working. Then what will happen? This will produce there will be no flexion force. If the flexor tendon FDP is not working, then what will happen? The EDC will, be there will be no counter force for EDC. So that will produce excessive MCP joint extension, excessive extension of the MCP. So when there is no counteracting torque of the EDC for the EDC muscle, what will happen? There will be a hyperextension of the MCP joint. So this hyperextension, just imagine, we cannot normally we don't have hyperextension because of the flexor torque which is present in the FDP and FDS. So when this is lost, what will happen? The MCP will go for hyperextension. So an isolated contraction of EDC muscle will result in MCP joint hyperextension with IP flexion. What will happen? If the flexor FDS FDP muscles are not working, the MCP level, it will go for hyperextension. But when they go for hyperextension, because of the passive what you call as a passive insufficiency, or the overstretched FDP and FDS tendons, mainly the FTP tendon will go for passive tension because they are overstretched because of the MCP hyperextension. So this will produce flexion of the IP joint. This is called as clawing. CLAWING, clawing. So clawing is basically due to the weakness of the FDS and FDP muscles, and which leads to hyperactivity of the opposing muscle, which is the EDC muscle. So what will happen in the MCP joint? Because the EDC muscle is hyperactive, there is no counter force in the MCP joint by the flexor tendons, it will go for hyperextension. So MCP joint hyperextension, but what will happen? Flexion of the IP, both IP, that is DIP as well as PIP joint. This is called as clawing, most commonly called as, when to commonly affect the ulnar muscles and the median. All the muscles have to, all the flexor tendons have to go, means both ulnar as well as median nerve has to go. Now, mostly we saw this clawing in the ulnar, which is 1.5 fingers is supplied. The medial 1.5 fingers are supplied by the ulnar. So we see both ulnar clawing as well as the total claw of the hand also we see. Similar to what we saw at the proximal carpal row of the wrist complex, clawing is a classic zigzag. So here it is a zigzag, right, like a Z, and that occurs when a compressive force is exerted across several linked segments, one of which is an unstable intercalated segment. In the instance of clawing of the finger, the proximal phalanx hyperextends on the metacarpal below, while the middle and distal phalanx flex over it. Normally, the collapse, which is extensive, here the collapse is the extension of the excessive extension of the proximal phalanx is prevented by active tension in the lumbrical or interossei muscle. So this flexion is actually collapse, that is excessive extension is prevented by the lumbrical and interossei, which plays a mild role of extension. We understood that earlier. They have a role in extensor expansion. So that will prevent excessive collapse. When the intrinsic muscles are weak or paralyzed, as in low ulnar nerve injury, the EDC muscle is unopposed and the fingers claw not only with active MCP joint extension, but always whenever it is in rest, the hand will be in clawing. The clawing at rest demonstrates the passive tension in the intact EDC muscle, even the passive tension of the EDC muscle also exceeding the passive tension in the remaining MCP joint flexors. So passive tension also exceeding even during the lower ulnar nerve injury. The clawed position is also known as intrinsic minus position because intrinsic minus muscles are minus absent. So this is the absence of